Welcome back. I'm Lisa again. So, I will be taking you all to the track 4 of this event. And in this track, we will be discussing about the best of patient safety initiatives. I am very pleased to welcome the chair for this track, Ms. Deepa Chuk, the nursing superintendent, Akash Healthcare member, ANEI. I would also like to invite the jury for this event, Dr. Sunil Munkur, Professor Pediatrics, Advisor Quality Kasturba Medical College, Manipal, Dr. VG George, our international member of ANEI, Doctor of Nursing Practice from USA, and Ms. Prajakta Hindalekar, Nursing Director, Chief Experience Officer, Breach Candy Hospital, Mumbai, member of ANEI. Now over to Ma'am Deepa.
Thank you, Lisa. Am I audible? Yes. So since morning, we had various insights from experts from various fields of life and from healthcare, basically. And we have been hearing about patient safety and all the aspects of patient safety per se. Now it's time to add wings to our budding professionals, and they have strived, believe me, the kind of projects which we have received, they have strived hard to bring safety to the patients. A multitude of initiatives were done pan-India level, and the best three initiatives in each category are here with us to share their insight. And let us first have a round of applause for all who have participated and put in such a hard work to come forward and represent their work at any platform. Bravo to all of them. And let us also put good luck to all the participants, three presenters for QIP and three for evidence-based practice. And good luck to each and every one of you. Now, in the pursuit of exploring the best patient safety initiatives, we have the privilege to having three distinguished personalities of healthcare with us today who will offer their valuable insights and judgment into the crucial subject. Let us welcome our jury. First, to welcome Dr. Sunil Munkur. Sir is a professor of pediatrics and advisor in quality at Kasturba Medical College Hospital, Manipal. So not only is a doctor, but I have seen him, his art and his dance is amazing. I would tell you, follow him on YouTube as well as on Facebook. So, sir, thank you so much for joining us and sparing time for us.
Thank you, Deepa ma'am.
Next, we have Dr. Vijay George, who is here from USA. In spite of the time differences, ma'am is here with us, sparing her personal time, being a weekend. It speaks volume for you, your dedication towards patient safety and your connect with we Indian nurses. Thank you so much, ma'am, for joining with us.
It's a pure pleasure to be here. Thank you, Ms. Deepa.
Thank you, ma'am. Next, we have Ms. Prajakta Hindlekar, shouldering dual responsibility and showing your willingness to participate and accept the additional responsibility for Annie. Ma'am, it itself is speaking how much dedicated a professional you are, and it is our pleasure to have you here as a jury. Thank you so much for joining us.
Thank you, and it's an honor and pleasure to be here.
Thank you, ma'am. Ladies and gentlemen, let us have a round of applause for our jury who have really put in hard efforts in the previous two the first line to identify the best three, and today it would be a task to them. Believe me, it is going to be a difficult task that they are going to put forward. Just to wrap up with our pleasantries, and now let me, sir, Sunil sir, you have anything? You have a raised hand?
No, by mistake.
Okay. So we shall begin the sequel of presentations. The first would be the three quality improvement projects, which would be there for almost 8 to 9 minutes. These are pre-recorded ones. After which we will have the evidence-based practices for 8 minutes, again 8 to 9 minutes. That would come around 50 minutes. And thereafter, the session will be open, the panel will open it for question and answer session, wherein our jury can ask the questions as well as the audience can also put in their queries or their questions on the chat box, or also can come live. So these would be the events, how it would be, and the results would be declared during the valedictory session. During that time, the jury would be in touch with each other and they would come up with our winners. I would request everyone to please stick on to the time because we have to complete the session by around 2:30. Post lunch session, I know the blood all has gone to our GI tract. However, we would make it as interesting as possible because these are our budding professionals who have come out with great ideas, and believe me, we also would learn abundantly with them. The first to initiate is Miss Karishma Khund, who is an ANS at Apollo Hospital, Guwahati, Assam. She would be presenting an evaluative study on medication administration process and impact on patient experience. Over to the first quality improvement project by Ms. Karishma.
Namaste to all present here. Thank you for shortlisting our QIP for this conference and giving us an opportunity to present. Our QIP topic, 2 words, engaging patients and families for safer care. Our project title chosen was an evaluative study on medication administration process and impact on patient experience. Why we have chosen this topic was medication errors are considered as one of the leading cause of patient harm in hospitalized patients. Nurses' role in the entire process is suboptimal as they can prevent the occurrence as well as the prevention of medication process. The project was undertaken with the objectives to evaluate the medication administration process of nurses and to identify various ways of involving patient and relatives, which will help us to evaluate the impact on patient experience as well. Today's era, patients and relatives are very much sensitive and vigilant for the role of healthcare workers towards treatment. Engaging them in this crucial step of medication administration process will certainly help in reducing preventable harms. Also, it will also help us to raise the bar of nurse-patient relationship into the desired level as required in this century. These are our team of our project. The problems in the background were lack of knowledge of clinical nurses on medication administration process. Nurses do not involve the patient relative in the final steps of verification for medication administration. Patients often complain regarding poor response of nurses during medication administration process, delay in medication administration, etc. Treating doctors also commonly raise concern on nurses' education on discharge medication during the patient exit. Lack of involvement of patient family in the entire process of medication and management, starting from prescription till administration. The main objectives of the project is to involve patients OK, as it acts as the last step and final verification of safety measures for zero error, to promote the patient's right and receive the right treatment, to demonstrate that no harm to patient and patient's treatment plan, to confirm that the patient acts as an advocate in preventing errors. With these objectives, we have taken PDCA cycle as a methodology. 3 months were the duration of the project from May 2023 till July 2023. A project team was initially formed in the pre-intervention phases consisting of CNO, ANS, nurse educator, medication nurse, and charge nurses. Few meetings were held to understand and review the current practices and training requirement, and finally audit process for evaluations. Medication administration process was already categorized under high-risk process initiative. An audit tool to assess the compliance to medication adherence process was developed, and it was formed in a Google link to check the compliance in daily basis. Another tool to assess medication administration process by staff nurses were developed, where 2 points were mainly highlighted. Take permission from patient relatives for taking out drugs from the drawer, and explain the details of the drug to the patient or relative with aided ensuring OK from patient or relative. Charge nurses were guided to do the audit of 2 nurses per day through this checklist. 5 P's of prevention of medication administration were learned and implemented. First P talks about prevention by involving patients using aided script. Second P is practice check. What audit process we talked about by the charge nurses. Third P is process check, where medication adherence audit tool were done in the daily basis. Fourth P is the prescript, which is a charge nurses or senior nurses are guiding the nurses in the bedside what to do, how to do, especially for the medication administration process. The format is attached here. Fifth P is a pledge. 6 rights of medication administration pledge were taken before starting the each shift by each nurses before starting their shift. In intervention phase, a flow chart on medication administration process was developed to train staff nurses primarily on involvement of patient and relatives. This flowchart were the part of Ready Reckoner. It was also pasted in the patient IP file so that nurses cannot miss a single step while dealing with the medication process. A video on medication administration process was also created for training the nurses. Toolkit on final check obtaining an OK from patient was introduced and implemented. The above mentioned toolkit is a group level initiative from Nursing Corporate Office under the Liver Service Excellence. After the implementation of this tool, this helped the nursing leadership to understand the root of causing errors which were preventable. This was also used as a training material to sensitize nurses about the importance of obtaining an OK before doing any procedure with the patients. Few examples of preventable errors. These data were captured from customer relation management portal, where patients can directly give feedback in day-to-day basis, and these are captured. Patient has given feedback of delay in medications. Nurses are giving nasal drop on eye. While doing the RCS of each error, it was found that all the errors could occur only because that nurses were not involving patient and family in their care. Like double dose of tablet Ventosis was administered to the patients, where one dose was administered by the attendant and another dose was administered by the nurse. So engaging patient and relative can certainly help us in reducing these kind of errors. These are the few pictures which were taken after the implementation of final check toolkit. This is the pledge for towards zero medication error was introduced with 6 rights of medication administration. The findings were surprisingly towards improving trends. Mainly, we could see the improvement in carrying the drug chart along with the patient file to patient bedside by staff nurse, taking permission before they take out the medicine from their drawer, explaining about DST, drug strength, and time to the patient and relative by the nurses. These all data were captured, real-time data from the Google link. Another findings of compliance of medication administration process, which was done by charge nurses for their staff nurses. These findings were discussed twice in a week in the departmental meeting. These discussions were also act as a post-error training so that such similar incident doesn't occur in the future. The process deviations were also shared to the nurses via WhatsApp group as a preventive strategy, where the points of improvement as well as their good point were also mentioned so that this acts as again motivation for the staff nurses to carry out the good practices. Another findings of compliance on medication adherence where improvement could see after we do these all implementations. These findings of patient appreciation, which were collected from Google review, online feedback portal, and various social media, really helped us, and these feedbacks could tell us that this quality improvement project really became successful by seeing the feedback. As patients are giving feedback that nurses are giving medicine on time, nurses are explaining the medication to the patient or relative, which was really grateful, and patients has really written down these feedbacks in different forum. To continue the same process, we thought of different solutions to carry forward. One is implementation of the final check toolkit and continuous follow-up, continuous in-service education, patient feedback analysis, and daily nursing leadership round, continuous audit process, patient family education. These are the solutions. This is my contact details of regarding any project. Thank you so much for this opportunity. Namaste.
Thank you, Karishma. It was indeed the hard work of the nurses as well as the implementation went on really very good. So round of applause for Karishma. Next we have in line is Mr. Satya Narasimha, Assistant Nursing Superintendent in Paras Hospital, Srinagar, Jammu and Kashmir. May I request Mr. Satya to, and his project would be on phlebitis. Thank you.
Hi, a very good morning to all of you. Myself, Satyanaga Narasimha Kumar, working as a assistant nursing superintendent and taking care of nursing education and quality in Paras Hospital, Srinagar. On the occasion of World Patient Safety Day, that is 17 September 2023, the theme engaging patients for patient safety. Our reputed and our own Annie, passion to action, have given us a wonderful opportunity to present on this platform. QAP theme. On towards zero harm, elevate the voice of patients. Under this, we as Paras Srinagar nursing team have chosen QAP on phlebitis. Let's go through the phlebitis QAP. Introduction. Phlebitis is one of the most common complications of the peripheral venous catheter and adversely impact future venous access. And bacterial phlebitis may lead to bloodstream infection. The objective of the study was to reduce the incidence of infusion-related phlebitis in patients admitted to the IPD non-critical and critical care units. Our team: Rashmi Suresh CNO, me Satya, Archana Devi infection control nurse, Lata Devi Shabdam and Ikbar respectively critical care and non-critical care in charges. The problem: phlebitis incident rate of 3.26 in the month of June and 3.8% in the month of July, 3% in the month of August, which crossed the benchmark of 1.3% in the critical care and non-critical IPD areas of Paras Hospital. And quarterly and department-specific phlebitis rate as shown in the figure. Aim and objective. The aim of the study is to reduce the incidence of infiltration and phlebitis by below 1.3% threshold benchmark. Objectives we have specified 9, and we have included patient and their families. To improve the knowledge and importance of phlebitis in patient and their families, to involve patient and their families to reduce the phlebitis rate, ensure nurses are knowledgeable about regular and normal saline flush, to improve the IV cannulation team, improve cannulation care and transparent dressing, improve best aseptic techniques, ensure nurses knowledgeable regarding selection of IV cannula, to be aware of nursing assessment on phlebitis, to acknowledge the cannulation process. Methodology. The study was conducted in the Paras Hospital, Srinagar. The unit is 100-bed functional, and we have audited 140 nurses, and from last 3 months we have audited 508 patients. And the phlebitis, defined as the veins ischemia inflammation, was assessed by VAP score and graded as 0, 1, 2, 3, 4, and 5. All phlebitis and infiltration cases were identified and reported according to the different stages of VAP score. The study designed in 5 phases: define, measure, analyze, improve, and control. The study qualitative and quantitative study. Time frame 4 months, June to September 2023. Methodology: DMAC cycle. Inclusion criteria: all IPD and non-critical areas, critical areas. Exclusion criteria: all OPDs. The methodology: DMAC cycle. The first 2 phases are define and measure from June to August, where we have developed a team with nursing in charges, infection control nurse, and guided by CNO, and the team audited all 508 patients. Next phase is August 23, analyze. And the team analyzed the phase August, and they have decided that 3.6% in June phlebitis rate, 3.8% in July phlebitis rate, and 3% in August phlebitis rate. Improve. As the nursing team and the doctor's team together decided 8 interventions that were likely to help the reduce phlebitis rate to 1.3 threshold benchmark, shown in solution slides below. And the last one, control. The committee decided assured that the mean of 1.3% of the threshold benchmark will not be exceeded from September 2023, and the audit report will be presented to management. The RCA. The RCA started with cannula insertion and end with phlebitis, and we have chosen 6 parameters: materials, methods, measurements, usage, environment, and manpower. You can see the internal parameters of that 6 elements. Findings: the lack of knowledge among 140 IPD critical care and non-critical nurses in the IV cannulation procedure and process, maintenance and care of IV cannula, and administration of medication. We have 10 elements for audit checklist. First is awareness of NS and POSI flushing, elements of peripheral bundle care checklist, standard procedure of IV cannula, knowledge of warning signs, knowledge of escalation process, knowledge of VAP score, knowledge of using Q sets, shelf life of IV sets, knowledge of high concentrated electrolytes administration, knowledge of broad spectrum antibiotic administration. The solutions as follows. Solution 1: usage of POSI flush and NS flush before and after administration of medication. Solution 2, IV cannulation, escalation pathway for IV cannulation team. 3, the peripheral IV cannula checklist for every shift for nurses. 4, usage of QSETs. 5, procedure of high concentrate electrolyte administration. 6, usage of chlorhexidine preparation before insertion of any cannula. 7, family and patient education form. We have included the VIP in patient and family education. 8, and we patient and family phlebitis form introduced and involve all patients in OPD and IPD. Control. Where 140 nurses assessed against 10 parameter percentage as shown in graph, there had been marginal improvement in phlebitis percentage from 3% to 1% in the month of September. Conclusion. A quantitative and qualitative study conducted by the nursing team reported an improvement in the IV cannulation process from September 1st to now. Last but not the least, quality is everyone's responsibility. Quality means doing it right when no one is looking. Thank you so much.
Thank you, Mr. Satya. You have proved that the patient safety initiative, which is started in India, is from Kashmir to Kanyakumari. So thank you for representing your state as well as coming forward with such a wonderful initiative of quality improvement project. And phlebitis is such thing where I think every one of us, be it any hospital, public sector, private sector, everywhere we are facing this issue. However, everyone is trying best. But yes, the solutions, the 8 solutions which you came out with were wonderful, and definitely it would be an aid to better insight to all of us who are attending it also. Next in line, we have Ms. Tinku Adhikari, Nursing Superintendent Quality Assurance at Apollo Multispeciality Hospital, Kolkata. Her work is on work safety today, work safely today and every day towards zero medication harm. Over to Ms. Tinku.
Walk safely today and every day towards zero medication harm. We created our project title for our quality improvement project.
At 1 o'clock night, the nurse entered with a syringe of narcotic. Sorrel told her there was an order for no narcotics, dear. The nurse responded that the order had been changed and gave Joyce the injection. Soon after injection, Joyce's heart stopped. In 2001, 18-month-old Joyce King died of dehydration and wrongly administered narcotic at world-famous hospital. Sorrel King has been written an inspiring memory Joyce story and has created patient safety program at that hospital. Keeping this in mind, know and check, engage with our patient for safe use of medications. A little error can cause a lot of terror. 1 in 20 patients attending healthcare facility is exposed to avoid medication harm. 1 in 4 patients face severe of life-threatening harm. More than 138 million patients are harmed every year by prescription error. 5 to 50% of all medical errors in primary care are administration error. Medication safety is defined as the freedom from accidental injury due to use of medications and medication administration process. So let me introduce with our team Ms. Mangala Chatterjee, Ms. Suchandra Ghosh, Captain Madhukari Ray, and myself Tinku Adhikari, working as a quality nurse. So why we have chosen this project? The nursing team has recorded 24 medication administration error from month of July to September 2022. Unsafe medication practice and medication administration were the lead to cause of patient dissatisfaction. The consequence of medication error is severe. The medication error can lead to numerous complications, including short-term to long-term injuries, temporary to permanent loss, death, life-threatening situation, even sometimes sentinel event. Nurses who are involved in medication error were found to suffer from emotional distress, lack of confidence, punitive action. So after seeing all these reason for medication error, we develop our objectives to ensure safe medication practice and focus on achieve zero harm, to improve the patient satisfaction on medication experience and empower patient and family to be actively involved in safe use of medications. So we have adapted methodology, DMAC methodology, define, measure, analyze, improvement and control. We have selected two CTQ. One is number of medication error, another is patient satisfaction. Current metrics: 24 medication error reported from July 22 to September 22. Patient satisfaction on medication administration was low, 35 to 70% from July 22 to September 22. Data collecting process through the close medical record and incident reporting. Data is defined, assessed and analyzed by QA, CPD, regular audit on medication error, prevention as on high alert risk process, CPD team audit on MMU3 standard as per JCI. So proposed matrix was patient engagement, zero medication error, no harm related error. After RC, we have presented a graphical presentation where we show the three major problem: multiple work at the same time, lack of patient and family engagement in medication process, and 7 rights of medication administration not followed. Sometimes medication order also are illegible and SNDT not followed. So process compliance check: an extensive audit conducted from October to December 2022 by the different audit tools. Audit tool on medication adherence followed, audit tool for patient experience and medication adherence, adherence of nursing monitoring chart, high alert medications. We have created a control chart that and show our journey of success of our project. In baseline data, there was average 7 to 8 medication error. After during intervention, there was 6 to 7 medication error, and this improvement says we can see the decline of medication incident of medication error. Patient experience on medication adherence, also we have checked the patient experience after receiving the medication. So improvement plan and solution, we have taken the 3 solution measure. That first solution is 5 P's, which we are following in our organization. We are doing the practice check, we are doing the prescription check, place to reduce error, prevent error and process check. Solution: engaging patient and family, taking okay from patient while administering medicine, empowering patient for safety, establish education on patient information leaflet, using of antibiotics at home, education on discharge medication including precaution to improve adherence and therapeutic use of medication, collected feedback on patient experience. We have adopted the evidence-based practice 5 moments of medication safety, where we denote or we educate patient as a stars. Stars means starting any medication, we should questioning, talking regarding any medication if required, adding when any medication is adding to their prescription, they should ask the question what purpose or why they are adding these medications. Reviewing medications, whenever there is a reviewing process, the total medication should review by the expertise. And stopping medications, also we should know the reason and why patient medication had been stopped. Process check of medication storage, we are checking the omit medications storage separately. Current medication are kept in medicine box with label, maintain 5S for medications and consumables, and maintain protocol of LASA drug. There are several solutions also we have adapted. So conclusion: with the evidence-based practice, 5 moments of medication safety, with 5 P's, the practice check, process check, pledge for reduce error, prevent error, and with the empower patient and families to be actively involved in safe use of medication, we achieve our target and we can see our quality improvement project success. Namaskar. I would like to thank Annie and our organization Apollo Multi-Speciality Hospitals, my group nursing director Captain Dr. Usha Banerjee, my nursing director Eastern Region Captain Madhukuri Ray for this opportunity. I also would like to thank Annie for providing us such an excellent platform for presenting our success. I believe coming together is beginning, keeping together is progress, working together is success. Thank you so much. Thank you once again. Namaskar.
Thank you, Tinku. It was such crisp, the three solutions which you have come up with, or I would say your team has come up with, the 5 Ps, the 5 moments, and involving the patient. Lovely. Though you have spoken about all other solutions, but these three definitely we can remember it and also practice it for all our patients. So we are here ending up with all the 3 quality improvement projects. मैं सिर्फ इतना ही बोलना चाहूंगी कि हर एक से बढ़कर एक है, and the jury would definitely have a task to have the judgment. Coming up next is the evidence-based practice. Now, evidence-based practice has emerged as beacon of knowledge, guiding the healthcare professionals in their decision-making and process. It's not only that a small study is taken and how QIP is done, it is at times beyond that. It is at times that you are looking forward how it would be at the bedside. It may look project-wise different on paper, but when we are doing it for the patient, it may turn out to be different. And we have 3 of our champions who have put forward their best efforts forward for the patient safety evidence-based practice. The first one amongst them is Ms. Ishita Chandra. She is Assistant General Manager, Nursing, AIG Hospital, Hyderabad. She would be, her evidence-based practice is on identification of best practices to reduce medication administration errors. Over to you, Ishita.
Hello, everybody. This is Ishita here, AGM Nursing, working in AIG Hospitals, Hyderabad. Thank you, Annie, and thank you, jury, for selecting our evidence-based practice on safe medication administration. So let me quickly pull up the presentation so that we can show you what small project that we have done and that has created a great impact on our patients as well as on the nursing practices. So we wanted to identify the best practices to reduce the medication administration error on the 10th floor of AIG Hospital. And to reach to our destination, we use the Johns Hopkins evidence-based practice model for nursing and healthcare professionals. We were following all the steps and the tools provided by this Johns Hopkins evidence-based practice. We did a PET process to derive a question and what is our goal that we wanted to look for. We defined our population, our intervention, what is going to be a comparison of the control group, how we are going to compare that, and also the outcome of it. We had our stakeholders who knew what role they are going to play in this study and what is the level of influencing to the management or leadership team to bring about the change in the practice. By looking into the level of our evidences and the research and the non-research, here we found that what our team thought was to bring about the traditional concept of medication nurse into present practice, but into a different form. But we couldn't get any such evidence to support that implication or implementation of medication nurse can reduce the medication error. But whereas we found a lot of things like, HIS or CPOE or EMR will reduce the prescription error, transcribing error, the working environment, giving a very good environment to the nurses where interruptions are not given, etc. Like this, they are basically not distracted while they are preparing the medication. Well said and done. In AIG Hospital, we have a separate cleaning utility room that is dedicated only for the nurses to prepare the medication, store the medication. We have the hygrometer installed to monitor the temperature. We have a hand washing area. We have a complete, good slab where the nurses can prepare the medications. In spite of all these things, still we found there were interruptions. There were medication errors. And in a couple of months, we are launching our EMR also. So what can we do right now before these EMR come? So we thought about how can we refine our process. So we took up this as a project to improve the process on safe medication administration by the nurses. This is our team starting out with the CNO, Ms. Bindu George, our senior leadership team, the midline leadership team, the staff nurses, the quality nurse, and the clinical pharmacist. I'm very much grateful to our 80 clinical pharmacists working in our organization who captures the data so well and helps us in presentation. So we wanted to know, where are we at par with WHO? And this is the graph that shows that we are still not at all on par with the data that the WHO displayed on the prescription error. We have a high number of prescription error. We had monitoring errors were high. And looking into the right side, that this is the errors that have reached or about to reach. This is all about near misses plus actual errors. Bottom, you can see the graph which talks about indenting error and the administration error all across our organization, as this too were the predominantly work done by the nurses. So we focus that we want to reduce the medication errors, administration errors by 50%. We wanted to reduce the workload of our nurses. We wanted to improve the knowledge of our patients, and definitely we wanted to further go about doing this project if the project was giving a favorable outcome. So why did we select this department particularly? This was a new department which has come. Occupancy was high, 20 beds, small capacity. Nurses were, most of them were the fresher nurses, and we had quite a good amount of medication error in this 6 months, in this last 4 months of initiating of this department. We laid down our inclusion criteria and exclusion criteria, which is already displayed over here. And we followed the focus PDCA model. So we found out the problem. The problem is eminent. It is well displayed here with the figures over here. Team sat down and we did a SWOT analysis. So we found out what was the strength, weakness, opportunities, and threat. And then we thought, let's bring out the concept of medication administration nurses. So we organized the team. We looked into our current process, and here we laid down as a flow chart. We also sat and discussed and found out what were the root cause analysis of all the medication administration error happen in our organization and pertaining to this particular flow. And this is what we have found, which is displayed on the screen. So what did we do a change? So we brought the medication administration concept. So we had 4 volunteer nurses who came willingly to take up this role of a medication specialized trained nurses. They were trained by the nurse managers, by the clinical pharmacist. We did a pre-test, post-test. We had drug presentation with them, and we prepared them specially only to do this task. So during that period, that is 6 a.m. to 9 p.m. in different shifts, these 4 nurses were coming. They were doing all the process of indenting, storing, administering, so preparation, administering, documentation, as well as explaining the medications while they are giving the medication. A small change that we did was, here in the previous process, the nurses were preparing the medications in the medication room and bringing the medications to the bedside, especially if I have to talk about the tablets. Here we told the nurses to bring the complete box to the patient bedside so that in front of them, they break the medicines, that they give it in the cup, and the patients are able to see that, oh, this is the box that where my medicines are being stored. They can see their patient's name over there, label, and also their bed number was displayed in the box. So this was the plan that we wanted to implement. And these were all the actionable items that we have discussed. So what was the fun? So if I take you towards the process, here you can see the nurse is preparing the drug. He is alone in that room, no other nurses, because he was in that shift. While he was preparing the medication, there was a signage board that do not disturb. So seeing that nobody, no GDA, no other nurses will enter that room, the nurse takes the medication box, explains the medication, gives the medication where the relative and the patient is there. This is the process, and he also explains the drug, and we did an audit on this. Now, what was the finding on this audit? We had a very good audit finding that in this floor, all our patients were able to list down the drug names and actions, which is very much impressive comparatively to the other floor where the patients were able to tell few drugs. They were not very confident about the action of the drug. What happened to a medication error? As you can see, the graph is displayed here. The medication errors gradually have come down, and the month of August and September, today we are sitting on 30th September, I proudly say that there was no medication error on this floor. And also some of the discrepancies, that is observations, were minor. That is the medication nurse have forgot to document it, or there was a delay in documentations of the medication. So this is the storage over here. You can see this is the training that we have done. They were also given additional help to update their knowledge, and the problem on HIs also was resolved here. So the result was favorable, and way forward, we want to replicate the same study in the other floor. And I'm very happy to share that this project is being taken in the month of October to the 11th floor. And we are very happy to share that our nurse managers have taken it into very positively, and they are willing to take up this project in further in the other departments also. So thank you, Annie, once again for this platform.
Thank you, Ishita. It was a lovely project, and I should tell you, your leadership is definitely visible. And I'm sure that the numbers which you have shown, the data which is being depicted in the graphs, have increased the patient safety. And we can definitely, all of us, look into it and have further debates also. I myself would have one question for you ready. Okay, going to my next candidate, who would be Ms. Kavita Chandrakar. She is a senior lead nursing research healthcare global hospitals enterprises private limited, Bangalore, and her evidence-based practice is on effectiveness of poster display on safe injection practice among the staff nurses at HCG Eco Cancer Center, Kolkata. Over to you, Kavita.
Patient safety is a fundamental principle of healthcare and is now being recognized as a large and growing global public health challenge. Every process of caregiving contains a certain degree of inherent unsafety of patients as well as for the professionals. Safety should be established as a consistent approach to guarantee that patient and caregivers will get the proper place and proper technique for appropriate treatment in a safe manner. So, we conducted a study on effectiveness of poster display on safe injection practice among staff nurses. According to the WHO, around 16 billion injections are given each year globally. Namaste all. We, the team of nurses at HCG Eco Cancer Center, Kolkata, wants to establish the medication safety along with occupational safety in a single time, as medication administration and generation of sharp is vice versa. It means patient and healthcare worker both are at risk. Patients and healthcare professionals are at risk of adverse infectious and non-infectious events due to unsafe injection techniques. The most frequent medicational operation carried out in any healthcare institutions is administering injection. Unsafe injection practices are widespread in variety of healthcare facilities in underdeveloped nations and are connected to a few healthcare related problems that can be avoided even while great efforts have been made to lower the number of higher dosages injections in developing nations. Still, the count is large. After a detailed knowledge and skill assessment, we found that the major errors related to medication administration were prescribing, dispensing, preparation, administration, transaction of care, monitoring with documentation, inadequate sharp disposal at the time of injection, along with inadequate communication. Since injections are intrusive operations that are regularly performed during a nurse's shift, having the right information and using safe practices are crucial to prevent the spread of infectious or harm to patients. With an estimate of 20 billion injections performed annually around the world, injections are among the most common medical operations. Healthcare professionals that lack the necessary knowledge, inadequate training, and not having adherence to safe injections practices guidelines for handling injections or their disposal runs the risk of exacerbating the issues. An injection risk, if adhered safely, neither causes harm to the recipient nor put the provider in any unnecessary risk and also reduces the production of waste that is hazardous to the surrounding area. Therefore, we tried finding out the root cause of error in injectable medications and sharp injury, as it causes negative effect and in return increases the risk of blood-borne illnesses which can be transmitted to patients or healthcare providers through needle stick injuries, increasing the cost of treating them. The aim of the study is to assess the effectiveness of poster display on safe injection practice for knowledge and skill among staff nurses in a tertiary care hospital. Pre-test self-structured knowledge assessment as well as skill performance assessment regarding safe injection practice was being conducted by administering multiple choice questions and skill audit checklist among 60 nurses. As a part of intervention, a poster display regarding safe injection at the site of injection preparation areas was being developed and administered among the study samples. Continuation to the study, a post-test was being conducted to assess the level of knowledge and skill regarding safe injection practices. After a detailed statistical analysis, the results reflected that during pre-test, 10% of nurses had adequate knowledge, 31.66% of nurses had moderately adequate knowledge, and 58.33% of nurses had inadequate knowledge. Whereas post-poster display, the post-test analysis highlighted 78.33% of nurses had adequate knowledge, 21.66% of nurses had moderately adequate knowledge, and none of them have inadequate knowledge regarding safe injection practice. Similarly, in comparison to pre-test, none of the nurses showed good performance. 78.33% of nurses showed average performance and 21.66% of nurses showed poor performance, whereas during post-test, cent percentage of nurses showed good performance regarding safe injection practices. The p-value is also significantly greater than the table value, thus signifying that poster display is effective in imparting an increase in level of performance among nurses in terms of knowledge and skill regarding safe injection practices. At last, we, the team of HCG, imparts adding life to years, expresses our sincere gratitude to our patients for their trust on our organization, and also to our true heroes, the nurses, who make a difference in daily outlook and comfort for our patients.
Thank you, Kavita. You very aptly proved the Chinese proverb which says, I hear, I forget, and I see, I remember it. So the display of poster is one very good solution, I would say one of the best solutions, and it has been proved a number of times. The best which I can think of right now is the biomedical waste. Wherever we throw our garbage, it is always there. The display is there, and it has been observed that we have really reduced a lot of mixture which used to happen previously. So a lovely study from your end, and I'm sure all of us can very conveniently, with whatever resources we have, we can display it. Next in line, we have Miss Stella Downsend, nurse educator at Kaveri Hospital, KCH, Chennai. Her evidence-based practice is on visual management tool to standardize the administration of chemotherapy to reduce the extravasation. Over to you, Stella.
Vanakkam all. First of all, I wanted to thank all the juries who have shortlisted our presentation. I thank one and all in ANEI, the vibrant leaders and all the dignitaries who are present over here. So our topic is visual management tool to standardize the administration of chemotherapy, and it is an evidence-based practice. Why we have selected this topic? It is because the cases of extravasation was heading up among the patients who are undergoing the chemotherapy, and it is a major complication, and we wanted to really prevent it to ensure the patient safety. So before going into the topic, I wanted to introduce my team. Our team name is Praditi, a Sanskrit word. It means a hope. Our team members, Ms. Anandi Satyakumar, our nursing director, Ms. Arokya Jayat, nursing superintendent, myself Stella Townsend, nurse educator, and Ms. Bhagavati, on-call charge nurse. A problem statement, a study to assess the effectiveness of the visual management tool which was implemented to standardize the administration of chemotherapy to reduce the extravasation in oncology unit. Our aim is to reduce and to eliminate the extravasation among the patients who are undergoing chemotherapy. Our objective to assess the effectiveness of the tool which we have implemented among the staff nurse in the study group. Severity of the problem. Yes, extravasation may lead to legal and ethical issues, and it may extend the length of stay for the patient based on the severity, approximately 15 to 20 days. And patient may even undergo additional procedures like wound debridement and skin grafting procedures, or even for the amputation procedure. It may result in the lethal effects. Why we have to eliminate it? It is because to ensure the patient safety, as I have already mentioned, and also for the patient satisfaction. Cost reduction by reducing the length of stay, and to maintain the hospital standard and the quality. Impact is there both for the internal customer and for the external customers. So internally, the staffs were feeling guilt about the practice because of the extravasation, why it is going wrong and why it is heading up. And for the external customer, there was the dissatisfaction among the internal and for the external customers. So because they were dissatisfied because of increased length of stay and also because of the lethal effects. Psychologically also they were affected. So methodology, what we have done is we have adopted the quantitative approach method, and research design which we have used is quasi-experimental non-equivalent one group post-test only, and we have done this in oncology department, and the nurses we have selected to satisfy the sample selection criteria, and sample size was 30, and we have adopted purposive sampling technique method. Need assessment scale which was used to identify challenges of the staff nurse working in oncology unit. Intervention, a visual management tool was implemented to standardize the administration of chemotherapy drugs and identify the qualified nurses, and we have sent them for the training and we have privileged them, and continuous nurse education program organized for the continuous knowledge development on extravasation prevention. And in post assessment, clinical pathway was created, and also we have updated the SOP for the extravasation and to prevent it, and nurse adherence to the evidence-based practice is evaluated frequently by cross audits, and also frequent audit done to rule out the effectiveness of chemotherapy administration. Our project title, application of PDSA, that is Plan Do Study Act, we have used to prevent the extravasation for chemotherapy patients. And the problem what we have to solve is to eliminate the cases of extravasation from grade 3 to 5, and also to reduce the extravasation from grade 1 and 2 among the patients who are undergoing chemotherapy. And critical to quality, patient who posted for the chemotherapy, and the target is to eliminate the corrective measure to reduce and eliminate the risk of extravasation. Deadline we have fixed from August 2022 to August 2023, that is the 1-year project. So in level 1, we have plotted the possible causes of 12 in the Ishikawa. In level 2, we have identified 6 probable causes. Those are: it may be due to wrong venipuncture site, or medication infused by unprivileged staff, or lack of awareness on types of medication they are using, wrong selection of infusion catheters, or it may be due to poor infusion or flushing techniques, or maybe because of wrong method of dilution. So based on all the root cause analysis, we have taken this period from pre-intervention period to post-intervention period. So during pre-intervention period, we found there were no standard protocol for the chemotherapy, no cannula characteristics, no privileged staff to administer the chemotherapy drugs, no training specifically for that, and improving knowledge and strengthening the competency. So during pre-intervention period, we have taken the cases of extravasation. Those were in grade 1, there were 18 number of cases were reported, and in grade 2 there were 12 numbers, and in grade 3 5 number of cases were reported, and in grade 4 1, and there were 0 cases in grade 5. During intervention period, as I've already mentioned, we have implemented the visual management tool and identified the qualified nurses. We have sent them for the training and we have privileged them, and we have conducted CNE programs for the continual knowledge improvement. So during that phase, we have seen the drastic decline in the cases which were reported, and during the post-intervention, clinical pathway created, and after extravasation protocol was updated, frequent audit done, and during that phase, you can see grade 1 and grade 2 there were only 1 cases, and grade 3 to 5 there were 0 cases reported. And p-value is a probability of obtaining, and that value was less than 0.0001, hence the study is significant. And you can see the direction of improvement, that is from the pre-intervention period. When you see the post-intervention period, the decline of cases, and it was declined to 0. And solution, we have done all the major root cause analysis. We have allotted the responsible person. We have taken various action, like we have sent the staff for the structural training program, that is for the various conferences, various certification program, and we have conducted like in-house training and expertise training. We have called the experts from the outside to train our nurses, and also knowledge regarding IV cannulation and techniques for chemotherapy, and hands-on training, especially knowledge awareness about the vesicant drugs. And we have also used the IVR mannequins to train them specifically for the selection of veins and flushing techniques also. After all this training, finally we have empowered all the nurses to inform about the lines and duration to the doctors to enable them to select the appropriate lines for the proper duration methodology in the chemotherapy. So root cause, what we have found is no specialized trained staff to handle the chemotherapy. Solution, what we have obtained is like identify the specialized nurse for chemotherapy, standard protocol and checklist had been implemented, and as a merit we have eliminated the extravasation and we have reduced the grades, and also demerits, there were no demerits. As a conclusion, this solution can be implemented and this practice can be standardized. So this is the image for your reference. This is the clinical pathway, a visual management tool which we have implemented, which I was talking throughout this project, which we have standardized the pattern of chemotherapy administration. And as a conclusion, I wanted to thank my organization and the medical superintendent, medical director and the nursing director who have supported for this project, and I thank you all.
Thank you, Stella, and bravo to the team who has put in such thoughts as well as solutions. Amazing solutions have come forward. Extravasation is one painful event if it happens to any patient, not only with length of stay. She has told a lot of things, that length of stay increases, the financial implications, the pain to the patient, dissatisfaction, everything. Also, the solutions were wonderful. Your clinical pathway was excellent. Now, may I request all the participants to please come on screens so that we can start with our Q&A. May I also request the jury to please come on screen. Few participants have given their questions. I would request all others also to please put it in the Q&A. Can we start? May I request the jury? May I request? Yes, ma'am. Yes, Dr. Vijay?
Yes, I just want to commend every team for this amazing work. And you all have done some great teamwork to bring practical solutions to the front line. The project shows that how frontline team along with the leadership can make an impact. So kudos and to all your effort, and thank you for bringing to this platform. And I can say for myself that it was really a tough job for us to say which one will be the best one. And I would like to hand over to other jury members to speak before we ask some questions.
Hello, am I audible?
Yes, sir.
Yeah. That's as rightly said by Madam. It was a fantastic effort by every team to bring down what was hazardous and dangerous in the healthcare setup. So kudos to the teams who have, in the bargain, helped the patients to get better and do no harm. Madam Prajakta, your comments, please.
Ma'am, you are mute. Please unmute.
Good afternoon to all, and I'm very proud Danian to be part of this jury. And a big shout out to all the participants. It's a team work from each project, lot of effort seen, and I'm sure in the coming years with these kind of platforms and forums being given for projects to be presented will bring lot of data, because in India we don't have Indian data for our solutions when there is a problem. So big congratulations to team and their guides and mentors. Thank you.
Any questions to be raised to the participants? From the jury, any questions from any of the participants?
I would like to ask Mr. Satya about one.
Ms. Satya?
Is he there?
Yes, ma'am. Yes, ma'am. I'm here only.
Mr. Satya, sorry.
Yeah, just one doubt. How did you select the benchmark of 1.3% in your study?
The benchmark is selected by PAN-PARAS, sir. And in PAN-PARAS, we have given from corporate that benchmark is 1.3% for phlebitis. And our quality manager, Dr. Rahul, and our doctors team decided that we need to keep only 1.3% as a benchmark.
What made them decide 1.3? Why not 1% or 0.5%?
What made that mean? They have senior consultants also decided, and our team here, before I joined, only the PARAS decided that 1.3% of benchmark for phlebitis.
Thank you.
Sir, if you don't mind sparing in 1 minute, for highlighting on this, because this is one point where many of us are having confusions on that how to set in the benchmark. So you are the best person to guide us on that.
No, I was curious about how they decided on benchmark. See, the easiest way is to find out what actually or as is in the last 3 years or last 3 months or before the study, how was the phlebitis levels, and then say how much intervention you can make to reduce it to say 0.5% improvement or 1% improvement. So that will be the best way to create a benchmark. Probably last 3 years phlebitis incidences you have to calculate and then keep a benchmark.
So say if we do not have past 3 years data with us,
Yeah.
then in those circumstances, how shall we come with the benchmark?
Second way, that is the best way, what I can say. Otherwise, you have to have national or international benchmarks from various study and fora, which will give you these benchmarks. Most often, you will not be able to extrapolate it to your setup because your hospital may be totally different setup. So it's always better to have our own benchmarks and try to improve on that. That's what I can say.
Thank you. Thank you. Dr. Vijay?
Yes, since we are asking Satya, so I thought like I will ask my question for Satya too. I have questions for others, but Satya, tell me what is the plan in place for sustaining this project?
Ma'am, the management decided that we need to continue this study till next year, April. And we need to sustain this below threshold benchmark only, below 1.3%. And we are doing our critical care and non-critical in charges are involving so much in that. And for every admission patient, the non-critical area, the non-critical in charges are involving patient and patient relatives during the patient family education regarding VIP. And also in critical care areas, we have started that we have timings for that, because in critical care areas, there is only visitor visiting is 2 times, in the morning and in the evening. At that time, the doctors team and nurses team together are explaining them regarding the VIP, because if the patient is shifted to non-critical area, then they know how to interface the IV cannulation problem. So the management decided to continue till April. If the threshold benchmark is not crossed till April, we don't have any, we can stop the quality improvement program. If it is not raised in between, then we need to continue till the Paras Srinagar is there. Till we are thinking that we need to do it for 6 months. If 6 months the threshold benchmark is not increased, then we will stop the QIP. If it is increasing in between, we will implement other things, ma'am.
Thank you, thank you. So can I ask another
Yes,
QIP,
yes,
or do we have to take turn?
No, ma'am. No, you can ask others.
Okay, thank you, Satya, for that. And my question is next to Kavita, the first presenter. So it seemed a lot of like lack of knowledge and understanding. So could you please tell, is that related to new nurses or increased turnover rate in your staff that has led to so much lack of knowledge among medication understanding among your staff?
Kavita?
Hello.
Are you there?
We have, am I audible?
Yes.
Yeah. So when we conducted our study, we have approximately 58% of the staff nurses who are less than 2 years experience. So we recorded from past 6 months, we are having 3-4 incidences of medication error pertaining to high risk medication, in which there were no cross-checking across with the seniors, right? And there were also errors during the dispensing of LASA drugs, and they used to take 4-5 medication together without labeling. So these are the incidences when our educators used to go to the rounds, they evaluated all these incidences togetherly. So what we thought that why these nurses, why we are not able to do, and we give more importance towards them in terms of teaching and demonstrating it so that we can achieve a proper patient safety care. So what we thought, and one more incidence is what we analyzed is needle stick injury. And the as we have already shown in the video, that they used to go with a plastic tray in which aseptic technique was not followed. So what we thought that why can't we have a poster display in which we have all our points segregated, and after the implementation of this, as we have shown in the other part of the video, to the corrected methods in which there was recapping was not done, and the housekeeping staff in the previous video who was discarding it. So we told them, it is your job to do that, not the housekeeping job. Then in the next video also we have showed that aseptic technique was followed and effective communication too. So we thought, why can't we have a poster display in our nursing station, and then the nurses' knowledge as well as the skill performance has increased up, and now recently from past 2-3 months when we have evaluated, there is no medication error.
Okay, thank you.
Can I go ahead, Deepa? My
Yes,
question
ma'am.
to
Yes,
Satya.
ma'am.
A very good project. Congratulations to you and the team and your mentor, Satya. I just have a question that, in the era of now ALOS, we have to monitor and, short stay patients. So do you have any data, the way you capture or, you prepare family when patients go home? Even some patients develop phlebitis after they go home. Is there any way or anything you can tell us?
Satya, I would request you if you can make it brief, your answers, because there would be multiple questions. It's not Satya, Kavita. Make it brief. Madam is asking your question.
Ma'am, actually, the Para Seniors Hospital started last 5 months back only, and the patient flow is also a little less here. And we started easily. We have taken all 508 patients are all our admission patients. For for short stay patients, we need to rethink that even if daycare patients are admitted, or if even from next month first, we are starting chemo daycare also, ma'am. We need to implement in that first, and we can see what the result will come for short-term patients and daycare patients. In this slide also, we have taken from emergency also, ma'am. When the patient have cannulation, we audited the cannulation procedure in emergencies and daycare. But the patient and family education we have given for only IPD critical care and non-critical area patients, which we have admitted last 3 months 508.
Okay, thank you. I think it can be a way forward, because I think this is on one gray area. From my experience, I have seen 2 patients coming with, leukocytosis, and the reason was the phlebitis post-discharge. And, it would help if you educate them after the removal of IV cannula when they go home. Thank you.
Ma'am. Yeah, ma'am. Thank you.
Dr. Sunil, so you have a question?
Yeah, this is a question to Ms. Kavita. We use pre-test and post-test mainly to assess the knowledge transfer. So how did you assess actually the skill transfer, improvement in the skills during your study? It cannot be based on pre-test and post-test. That actually should be on observations. And you had not defined what is meant by good, average, or poor performance in the skill improvement.
Yes.
So just wanted to know.
Yes,
curious about this.
Yes, sir. Actually, sir, knowledge, as perfectly mentioned by you, knowledge we have assessed in terms of MCQs, and in terms of skill performance, we have assessed with the help of observation checklist of how they are performing it, right? And in our study, which I have sent the slides for the jury, in which we have mentioned that performance level we have divided into poor performance, average performance, and good performance, in which we have given the percentage terms like less than 50%, 51 to 75%, and more than 76% describes about the good performance. So
I could wrap up by saying that you had used an observational checklist?
Yes, absolutely.
Okay, thank you.
Okay, thank you.
Can I have a quick question to Ishita?
Yes, ma'am.
Yeah, I think a very good study. You had mentioned in your slide that you have 80 clinical pharmacists, and which is quite a large number. So I was really impressed, and many hospitals don't have that privilege. So are they really what is their role in your study that you have taken their help?
Our setup is a big setup of 800 bedded hospital. So capturing data becomes a bit difficult. And, nurses or anybody proactively will never come and tell that I have done a error. So we always, we have this CPs, clinical pharmacist, who does all the audits of the new orders. So since ours is a JCI hospital, so as per PAR, that we have all, within 24 hours, all the orders have to be verified, rectified. They go to the patient side, they check on the dilutions when the nurses are doing. So they have round the clock, they do audits. And they also train the nurses. So that helps us in identifying, like delayed in administration, actually they observe. So they have a lot of observational process that they do it in day to day to capture data.
Thank you. You had excellent patient involvement initiative, and I must congratulate. And you mentioned about the medication administration from 6 p.m. to 9 p.m. So that was, if you can tell me what was the idea to take that time?
Ma'am, this was just a pilot. So, my challenge was many nurses were not willing to come, first of all. And then we did a study before that how many patients are getting, what is the average medications each patient were getting. So we found out 5 medications per average each patients were giving. And their time duration was maximum from 6 a.m. to 9 p.m. Usually in the night, there was no medications given unless it is an early morning 6 a.m. So that's why we scheduled it like that.
Okay, thank you. All the best for your, more implementation in other floors.
So thank you all. I am sure this is becoming really very interesting, but with the tight schedule which we are having, I'm left with only 30 seconds to wrap up. Wholehearted thanks to the jury, and the jury's work starts now. The presenters, lovely projects, and you have given a task to the jury post lunch to work hard now on your projects, and we will have a validatory session wherein the winners would be announced. Till then, we have to wait and keep our fingers crossed. Good luck to the presenters, and I'm sure you'll come with flying colors. Ma'am, I hand over the platform to you now. Lisa, is Lisa coming back?
Yes, ma'am.
And bravo, we completed in time. Thank you.
Thank you so much for the real success stories. And we will have to wait till the valedictory session to know the prize winners from these finalists. I will now wrap up the track 4, handing over the next track to Ms. Aditi Sharma. Thank you.